Dr. Puneet Verma, Director and Chief Interventional Cardiologist and Structural Heart Specialist at ACE Heart and Vascular Institute, Mohali. Thank you so much, gentlemen, for joining us today, and really appreciate you making the time. Now, first, let's start off with, coronary heart disease, and as I said at the outset, it's actually the largest killer that we have in our country. So let's understand how widespread is it? And let me pose that question to Dr. Puneet. Dr. Puneet, when we talk about heart disease, it seems to be that every second person, including celebrities, appear to be falling prey to heart disease in some form or the other. How prevalent is it in our country, and is there a specific reason that we are suddenly seeing this spike or rise in heart disease in the country?
Thank you. Good evening, everyone. Yeah, it's a very relevant question in today's times, especially knowing that India is and was always the world capital for heart diseases and certain other risk factors like diabetes. But we have seen of late that this coronary artery disease, is indeed spreading like wildfire in our country. And the prevalence, I would overall think that yes, minimum at least 12 to 15% prevalence of this disease is there in our country. And maybe in regional areas it may be even more. For example, at one time we were very sure that there is a north-south divide in our country between South India having a greater prevalence of this disease thanks to certain eating habits in the regional areas of the country. But on an average, I would put it around 14 to 15%, no doubt about it. And yes, the skewed prevalence in our younger population of late has come up, and that we believe is certainly attributed not only to the emerging risk factors which we have found in our young population of a faulty lifestyle, poor eating habits, bad balanced diets, in case we were to use that word of not able to regulate the constituents of their diet, which we actually call as a nutritious diet. And certainly the newer lifestyle habits of alcohol, smoking, and maybe certain other substance abuses which have actually taken the younger population by storm, especially in states like Punjab and all, where we find drug addiction a very common problem in our youth. So I guess collectively and not able to manage our conventional risk factors as well, diabetes, hypertension, high blood pressure, or cholesterol abnormalities. So they all, apart from whatever genetic tendency we may be having thanks to the genes which we have carried from our forefathers, but our lifestyle overall has certainly contributed to the growing prevalence of this disease in our
And indeed, this is grim news. Basically, like the youth and younger people are suffering from heart disease and particularly heart attacks. I mean, that's what we are seeing. I mean, it's become commonplace almost. And today we are here to talk about one more innovation, a new technology which is there. And let me turn to Dr. Puneet Verma with that question, because we heard about the first kind, which is your metallic stents. Then there are stents which, give out a little bit of a drug which prevents the arteries from closing again. So today we want to talk about another newer kind of stent, which is the Bioresorbable Scaffold, or BRS, which are also known as dissolving stents. How do these work?
As rightly said by Dr. Saxena about the kind of stents we've been using, they all have had a metallic platform so far, whether it was stainless steel to begin with, and then that gradually we upgraded the technology to a cobalt chromium or a platinum chromium platform. But the problem with the metal stents obviously was that whenever you put a metal stent in any artery, it becomes a slotted tube, whereby while you have opened the artery and you have got the acute benefits which you could provide to a patient, the long-term benefits of that particular slotted tube to the function of the heart sometimes get compromised, that the arteries do not regain their natural functions, their biological functions are never brought back in such slotted tubes, especially when you are putting long stents in arteries. So in Indians, we understand that we have diffuse coronary artery disease, which is a problem, especially even seen in younger patient population. And in select subgroup of patients, we believe that, especially in the younger population, since we are discussing premature coronary artery disease in our population, that these scaffolds could have a defined role, not in all patients, but in a select subgroup of patients, which, as per our discretion and our experience dictates, we would certainly like to use these absorbable scaffolds, which are made of medical grade polymers instead of metal, which dissolve over a period of time of 2 to 3 years. And then once the stents the scaffold has dissolved, the natural functions of the arteries are also restored back. And especially in the main arteries, the 3 main arteries of our heart, especially if we plan to do an angioplasty in their major segments, which are badly affected, then we believe that these resorbable scaffolds, which practically have very negligible rate of restenosis and thrombosis. Thrombosis means acute chances of a stent closing down while the patient is in hospital or even in the first 1 month of the procedure.
So this is fascinating how science has evolved from metallic stents to now these kind of reabsorbable stents, and especially for the younger population. And we are seeing an epidemic of sorts when it comes to heart disease and heart attacks amongst the young. Welcome back to our series Treatment Zaroori Hai, brought to you by Merrill, and today we are putting the spotlight once again on heart disease, which is the biggest killer when it comes to Indians, and indeed we are seeing more and more young people getting impacted, so it's important to know about the latest technologies. Let me go across to Dr. Puneet Verma and really understand in terms of how well aware, for instance, or how well trained are doctors. What's the kind of supporting infrastructure? Dr. Verma, particularly when it comes to, for instance, these reabsorbable stents, what's the kind of record that you've seen for surgeries here in India? What's the supporting infrastructure that is available that a patient can go in with a mind at ease, saying that he is getting the best available treatment?
Implantation of a bioresorbable scaffold is essentially an angioplasty only. Please remember that. And on-site, when we say that you have a cardiac center, so we obviously mean that you have a good working cardiac cath lab, which has a good resolution to work with. And generally in today's digital technology, we all work with the top-end labs only. That's number one. And obviously, you must have a supporting cardiothoracic surgical program also, which is running in your hospital. Having said that, this CTVS backup, as we say, is not an essential criteria where you have to address emergency surgery, emergency angioplasties in your hospital, especially like Dr. Sudhir mentioned about treating heart attacks with primary angioplasty. But when you have to do complex coronary work where patients come to you electively for such kind of work, then you must have a good discussion with your heart team, with your cardiac surgical team regarding whether we should be proceeding for an intervention or should this patient benefit from an open heart surgery. So as to say that you must have a good experienced cardiac surgical setup in your hospital, along with a good working cath lab, wherein you must have access to certain other imaging technologies as well, like intravascular ultrasound and the other imaging technologies like OCT, etc. But when you have to do a procedure like TAVR, TAVR is again something that TAVR is rarely would be done in an emergency setting, unlike stent implantations, though people worldwide have sometimes dared to do it in emergency settings as well. But since TAVR is an elective procedure, and we believe that it should be well discussed out with our cardiac surgical colleagues as well as with the patient. And whenever TAVR is done, even though we have rarely seen the need for a CTVS backup coming up in such patients when we do these procedures, but a surgical risk of the procedure always exists, and therefore you must have a surgical theatre on standby in your hospital with a cardiac surgeon ready in the hospital whenever we do these transcatheter aortic valve implantations.
Okay, so essentially with TAVR, one has time on hand. It's usually not done in an emergency setup, and hence mostly, okay, in most cases. But when it comes to the utilization of stents, that is done more, perhaps the likelihood of it being done in an emergency or where time is short. And that is when these quick decisions need to be made. Heart disease. Dr. Verma, what would be your message today to our viewers? Because whether it is in the context of heart disease or in terms of treatments which are available, how important is early treatment, early detection, and planning for some sort of necessary steps to really arrest further heart disease?
That's of paramount importance considering the epidemic of disease which is occurring, which our country is going through. And as I said in the beginning also that these are all lifestyle, majority of them are all lifestyle aggravated issues which we are genetically predisposed to, being in our Asian Indians we believe that this disease is more rampant thanks to our genes, but certainly aggravated by a faulty lifestyle. And believing in the mantra that obviously prevention is better than cure, it stands to reason that early detection of these diseases, especially the lifestyle-related diseases like coronary artery disease, hypertension, diabetes, etc., the screening should all begin early in life. While in USA, people start getting screened for as early as 20 years of life, especially when, say, a child has just entered college after schooling and all. In India, somehow we have a general inertia towards it that we don't like to get our children examined and expose our children to these executive checkups which actually should start early in life. So maybe I would recommend that it's not 20 years, and certainly at 30-35 years regular periodic screening should be done. I would still recommend 30 years should be an apt time, knowing that we Indians acquire the disease, especially lifestyle diseases, at least 5 to 10 years earlier compared to our Western counterparts. So I guess this is the general advice for all the youngsters across the country also, even if we think we are fit, but whether we really are internally fit or not, how well are we in terms of our cardiovascular health, fitness and stamina is all something which should be objectively documented at regular intervals.
Indeed. So thank you so much, doctors, for sharing all your valuable knowledge, insights, and most importantly, your valuable time today, because I'm sure you've helped more than one viewer, whether it is in terms of identifying their symptoms, going ahead and seeking treatment, or just getting those annual checkups. We all need to take those steps today because one can't escape from the fact that treatment is Zaroori Hai, particularly when it comes to heart disease, and be aware as patients, as doctors, about the latest technologies which are there at hand to help us all towards the recovery path. Thank you so much, doctors, and thank you to our viewers for joining us.